Now today we will do the thoracic duct. So thoracic duct is a lymphatic channel or lymphatic tract which is present in the posterior mediastinum of the thorax, and it collects the dead cells as well as the disease causing organisms from the tissues and throw them into the blood circulation, that is in the bloodstream. So this thoracic duct is 45 centimeter long, and it contains a milky fluid, that is the lymph, and this lymph is called the chyle. So this milky fluid is mixed with the fat material or the fatty material and plus the other debris of the tissues and make the human body disease free. The thoracic duct wall contains smooth muscles also, and it also contains valves like the veins, and these valves they help in the unidirectional flow of the lymphatic fluid. The thoracic duct drains the 75% of the lymph from the human body. The rest of the 25% of the lymph is collected by the right lymphatic duct and thrown into the blood circulation. This thoracic duct almost covers or drains whole of the lymphatic drainage under 75%, except the thoracic duct doesn't drain the area, that is the right side of the head and neck area, number 2, right upper limb, right breast, so these areas are not drained by the thoracic duct, but the other duct will cover the head and neck area, preferably neck on the right side, the right upper limb, the right breast. So these areas they are by the different from the thoracic duct drainage area. Now the thoracic duct origin. Then we will discuss about its termination, and then its tributaries, and its course, and then lastly we will discuss about its applied or clinical importance. So thoracic duct we have to discuss under these headings. So origin is the starting of this thoracic duct. So this thoracic duct, it originates or start from the abdomen. As you know, thorax and abdomen, they are separated by the abdominothoracic diaphragm. And this diaphragm has got a opening in the midline at the level of the T12 vertebra. So at the T12 vertebra, there is the aortic opening is there through with the thoracic aorta becoming the abdominal aorta. Just right side of this median arcuate ligament or the aortic opening in the diaphragm, there is a irregular sac is there. This irregular sac is nothing but the confluence of the lymphatics of the abdomen. So lymphatics from the abdomen, they reach the thoracic vertebral level and they all drain them into a saccule-like structure, which is called the confluence of the lymphatics of the abdomen. So from all the organs from the abdomen, the lymphatics they start. And when we see the lymphatics, they start as the blind tubes. If we see closely, these blind tubes are having the many perforations or the holes. And through these holes, the debris, they are sucked by the lymph milky fluid present inside the lymphatics, and they are thrown into the lymph nodes which are connected to these lymphatics. So these lymphatics, they are like the blind tubes, they are like the vacuum cleaner. Like if you put the nozzle of the vacuum cleaner in any corner, it will suck everything. Same is the lymphatics. So it will suck all the debris and they thrown into this cistern. So this saccule of the abdominal side is called the cisterna chyli. Cisterna chyli. So it is the confluence of the lymphatics of all the organs of the abdomen. Then from the upper end of this, so T11, 10, 9, 8, 7, 6, 5, T4, T3, T2, T1, the first thoracic vertebra, which is attached the first rib, the inner border, outer border, and the scalene tubercle. And to this scalene tubercle, we know there is the attachment of the scalenus anterior muscle. And this scalenus anterior muscle is very much related to the phrenic nerve. And there are two grooves on the superior surface of the first rib, that is the anterior and posterior groove, one for the artery and other for the vein. So this is on the right side. Left side, that is the how the first rib is present, forming the thoracic inlet. And the scalene tubercle, anterior to this there lies the subclavian vein, and posterior to the scalenus tubercle is occupied the subclavian artery. So like the origin, so the thoracic duct originates from the upper end of this cisterna chyli, which is present in the aortic opening on right side of the abdominal aorta. So here is the start of the thoracic duct. So thoracic duct runs vertically upward up to the T4 level on the anterior surface of the bodies of the thoracic vertebra. On the left side, there lies the aorta, and on the right side lies the azygos vein. So that is the relation of the thoracic duct. Azygos vein on the here and abdominal. So this is the starting of the thoracic duct at the level of the T12. Now at the level of T4, this thoracic duct turns on the left side. From T4 to T6 level, it turns on the left side, then it ascends upward. As you know, this is scalene tubercle is there, with the scalenus anterior muscle inserted over the scalene tubercle, and the phrenic nerve is crossing it and anterior to this lies the subclavian vein on the both the sides, anterior groove on this first rib. So this is the origin of this. Then the termination. This thoracic duct will end into the junction of left internal jugular vein and left subclavian vein. As you know, the left internal jugular vein and left subclavian vein unite to form the brachiocephalic vein. And this brachiocephalic vein, it crosses to the left side, right side. And here, same on this side, right internal jugular and left subclavian vein unite to form the right brachiocephalic vein. Both the right and left brachiocephalic veins, they meet on the right side to form the what is called superior vena cava. Superior vena cava is formed like this. So this thoracic duct, it turns on the left side behind the subclavian internal jugular vein, anterior to the scalus anterior muscle and phrenic nerve, and it open into the there. It open into the junction between the left internal jugular vein and the left subclavian vein. And at its termination, there lies a bicuspid wall. This bicuspid wall may be in the internal jugular vein or it may be in the subclavian vein. This bicuspid valve helps in the unidirectional flow and it prevents the mixing of the blood not to go into the thoracic duct. So a bicuspid valve is already present here at the junction, and this bicuspid valve make the not to enter the blood, cannot enter into the thoracic duct. Only the lymph from the thoracic duct can enter into the bloodstream. So this here lies the what is called bicuspid valve at the termination. Another important thing at the termination is that at the termination here lies a single lymph node. Single lymph node is present attached to the terminal end of the thoracic duct, and this single lymph node is called Virchow's lymph node. Virchow's lymph node. So that is the termination. Now come the tributaries. Various lymphatics from T6 to T12 is collected from the intercostal lymphatics. So the lower 6 tributaries, they come from the thoracic cage. The upper 6, that is the first, second, third, fourth and fifth, all these lymphatics, they ultimately open singly into the thoracic duct. So these are the tributaries. Beside these tributaries, the other tributaries, they may come along the internal jugular vein also. They are called the jugular lymphatics, and they open into the thoracic duct. The lymphatics from the along the subclavian artery or vein, it may also open. So they are called the subclavian lymphatics. So other lymphatics, they come from the neck region, which opens into the thoracic duct. So they are called to be the tributaries. Then the lymphatics accompanying the brachiocephalic vein, they can also open into the thorax. So these tributaries are opening into it, and these tributaries, they are subclavian lymphatics, brachiocephalic lymphatics, jugular lymphatics, and the upper 5 intercostal lymphatics channels, they open into that. After that, we go to the course. Regarding the course, as we already discussed, that it goes upward from the cisternal vertically on the right side, between the iliacus vein on the right side and the abdominal aorta on the left side, and collecting the tributaries. Along these tributaries, they are present the lymph nodes. They are very small lymph nodes are present along the thoracic duct, which gives the beaded appearance. And these lymphatics, they drain the posterior mediastinum and the lungs and the heart also. And these lymph nodes, as they present in the posterior mediastinum, they are called the mediastinal lymph nodes. Mediastinal lymph nodes they are called. So that is the course, the starting and the termination. Now the last comes the upright of the clinical importance. The clinical importance of the thoracic duct is, number one is the chyle thorax. The chyle thorax is the condition in which there is a accidental cutting of the thoracic duct may be there. It may be due to bullet injury or the knife injury or the stab injury. So whenever this thoracic duct is cut, it leads to the release of the lymphatic milky fluid in the pleural cavity. So this condition is called the chyle thorax. Another condition is the virtual lymph node. We know virtual lymph node is a single lymph node attached to at the termination of the thoracic duct. If this lymph node is stony hard, and if it is enlarged, then it is the diagnostics of cancer of the any organ, the abdomen and the thorax. Because the thoracic duct drains the whole of the abdominal organs as well as the lungs and the heart also. So any cancer cells from these organs, they travel through the lymphatics and they reach the cisternal and through the thorax and they reach the single lymph node, that is the virtual lymph node, which gets stony hard. So that is the clinical importance of the single lymph node, the virtual lymph node. Another condition related to this is the lymphatic cervical fistula. In this condition, what happens if there is any operation is done in the lower part of the neck, then due to the surgical negligence, there may be cut of the thoracic duct. The cutting of the thoracic duct will cause the release of the lymphatic fluid in the lower part of the neck, and this lymphatic fluid may come out through the skin, and so patient will present after post-operatively, patient may present with the release of the milky fluid from a fistula. So this fistula is the post-operative complication of the surgical maneuver done in the lower part of the neck. Then the elephantiasis. So elephantiasis is the condition in which we know it is caused by the protozoa, that is the Wucheria bancrofti, and this protozoa is very fond of the lymphatics. So these protozoa, they grow in the lymphatics, they get the nutrition from the lymph, and because of the overgrowth, proliferation of these protozoa in the lymphatic channels, so what happens? They block the lymph nodes, they may block the thoracic duct, lumen, and the lymph nodes, they become very much enlarged. And because of the blockade of the thoracic duct, so this thoracic duct appears to be irregular in outline and may be dilated at places. And the lymph nodes, they are very much enlarged. So in the X-ray findings, in the elephantiasis of the posterior mediastinum, the thoracic duct is irregular in shape, is not vertical normally, and there are white patches are present around the because of the enlarged mediastinal lymph nodes. So that is the finding in the elephantiasis. So they can block the lymphatic, and this blockade of the lymphatic channels or thoracic duct may lead to the reversal of the lymph to the organs, and that lead to the lymphedema. So because of the lymph collection in the organs they become enlarged and they become swelling, so edema is there. And slowly all the organs they undergo multiple organ failure because of the collection of the lymph. So that is the elephantiasis also very much related to. In other ways, any metastasis cancer cells, they travel and the mediastinal lymph nodes they get enlarged. And the mediastinal lymph nodes, when they are enlarged, they may be enlarged in the other conditions of that is the lymphoma. So lymphoma is a primary tumor of the lymphatics or lymph nodes or lymphatic channels, or it may be secondary because of the cancer cells metastasis. So due to any reason the lymph nodes, because of the cancer primary or secondary, they get enlarged, and these enlarged lymph nodes they press the thoracic duct from external side, and the pressing of the thoracic duct from the enlarged lymph node lead to the obstruction in the flow, upward flow of the lymph. So in this condition also, the lymph will go back into the tissues, and that lead to the lymphedema of the tissues and the organs. So that is the condition also related to the cancer or the lymphatics. That's all.